Next up is Robyn D'Oria. I'm sorry, I'm got word problems today. Who will talk with us about the AIM hypertension bundle, and some of the changes that have come with that, or the updates to it, I should say, amongst other things. I don't have anything to introduce you with, so I don't know if you want to give yourself a quick intro, unless Margie has something.
Well, you know, I always do. Robyn and I at National A1, I said, Robyn, could you please come speak to FPQC? Robyn was on the actual AIM, the bundle update. She is the CEO at Central Jersey Family Health Consortium, and she is one of my AIM colleagues as a National A1 leader. She is the New Jersey A1 section chair, and she is the co-chair for the New Jersey Perinatal Quality Collaborative. And I learned when she came to visit that she's actually the Preeclampsia Foundation Board Chair, which I did not know, Robyn, before you came to Florida. So it's such an honor to have you again, Robyn. I always tell my colleagues at A1 how thrilled we are that we had you, and how everyone really enjoyed your presentation. So thanks for coming back.
It is my pleasure. You guys are wonderful, and you are doing such phenomenal work. Trust me, New Jersey has looked to Florida for much of what we do, because you are all leaders. So it is an honor and a privilege to be here. And thank you. This is fabulous. I have to be honest, it is tough following Mandy, because when I hear Mandy's story, it goes right to my heart and pretty much solidifies why we do what we do every single day. And that could be in the hospital, or it may actually be in the community. And I will share with you, I'm a nurse for a long time, for over 40 years. And the first half of my career was spent in acute care. I'm a perinatal clin spec, and I had a variety of roles. Started as a labor and delivery nurse, and was at the bedside, and eventually went to administration. But then I got the opportunity to join an organization called Central Jersey Family Health Consortium, which is a not-for-profit 501c3 in New Jersey. And what we do are public health initiatives in the maternal child health sphere. And as a nurse, I thought our hospital, of course, was the best, and we took the best care of our patients. And when they left with that bundle in their arms, they were set for success. Little did I know that it wasn't always the case. And those few extra diapers and maybe a couple bottles of formula were not going to meet the needs of that family. And I have spent a little over 20 years in this role, leading this organization, and it truly has opened my eyes, but has really been a great opportunity. Next slide. So I know when you think of New Jersey, this is what you think of. We're just up the East Coast, and honestly, okay, maybe parts of this are true, especially if you go on the New Jersey Turnpike. Next slide. But this is my New Jersey. New Jersey is very diverse. We have urban areas, we have suburban areas, and we have rural areas, believe it or not. And unfortunately, I have to say, within the past year to 2 years, we actually will have OB deserts located in our state, which is really kind of blows my mind to think that could be possible. Next slide. So just to level set where we are, this is why we're here. Obviously, this just shows the United States in comparison to other industrialized nations. And I always tell people I'd much rather have a baby in the Netherlands as opposed to the US. And honestly, if I'm a Black woman, I definitely do not want to be in the United States. As we know nationally, they're 2 to 3 times more likely to suffer a mortality than their white counterpart. In New Jersey, that number was up to 6 to 7 times more likely. New Jersey has not had the best record for maternal mortality. And in fact, we were one of the highest states. If we have time, I'll share with you some of the initiatives that we've been implementing since 2019. And we have really improved by at least 20 some odd states. So some of the work that we do, I believe, is working. And the reason it's working is because we've included the community in our efforts. Next slide. Again, 40 years ago, nobody talked about maternal mortality ever. And I mean, I truly come back from the days where we had glass IV bottles and delivered alcohol via those IV glass bottles to stop preterm labor. To think about where we are today it's fabulous. But why are we still having these horrific data points that speak to maternal mortality? It wasn't until around the mid-2010s that we started to really talk about it out loud and speak to what some of those issues are and why are women dying during pregnancy or afterwards. And I have to bring your attention to this Lost Mothers series, which was in ProPublica. If you're not familiar with it, this series, which ran for a number of years, and the primary author, Nina Martin, is still involved in this space, not with ProPublica anymore, but really documenting all of the issues surrounding maternal mortality. We know that it's not one thing that's causing women to die. Linda spoke earlier about the incidence of morbidity being 100 times greater than mortality. We do have work to do. And it continues, as you can see, an article that just was printed in 24 that really is starting to talk about the data and are we measuring the right things. Next slide. This is an important concept. Now, I know I'm preaching to the choir, but the reason I included this slide is when you look at the data, you want to be sure that you are comparing apples to apples. Depending on the source of your data, particularly as it relates to mortality, some sources actually measure the death of a person either while pregnant or within 1 year of pregnancy, regardless of the cause or the length of pregnancy. Those deaths are called pregnancy-associated deaths. And when you look, that gives you a number or a rate. If you look at World Health Organization's data and some other national databases or global data, they only report out to 42 days. So things get a little wonky when you're comparing. So please be cognizant when you're talking about maternal mortality, what we are speaking to. We now have maternal mortality review teams, and one of your team members at FPQC is actually attending a meeting today. Ours is in 2 weeks. And they're looking at those pregnancy-associated deaths. After they look at obstructions regarding that death, they then determine whether the death was pregnancy-related. So had she not been pregnant, would she have died or not related? In other words, it truly was an accident. And there are some deaths that we really aren't sure of, and those are undetermined. Next slide. There are now almost every state in the country has a maternal mortality review team. That's important because it was only a few short years ago, and certainly in my tenure, because being part of the group that actually designed the National Obstruction Tool, we only started doing that around 2015, 2016. At that time, there were maybe 20 states at most or jurisdictions doing that. Why do we care? We care because now we're able to actually compare apples to apples. We're using the same abstraction tool, the same data metrics, to be able to measure and look at trends across the country, as well as within individual states. Next slide. So there is a report by the CDC, and this is under the auspices of the CDC and their Reproductive Health Services branch, that puts out a report every year or so. Their latest report that just was reported out last year, and if you went to A1's national convention last year, there actually was a session on it, and these data are from that session. There were 38 states that contributed to this report, and there were 525 pregnancy-related deaths reported. Now remember, pregnancy associated would be a bigger number, but out of that larger number, 525. Next slide. In that report, we see the leading causes of death for pregnancy-related deaths. And I bring your attention to mental health conditions. We're not going there today, but keep that in mind, as well as cardiovascular conditions. And they do actually break that down by cardiomyopathy. Infection actually rose dramatically within this report, and it is because of the incidence of COVID. When you include 2021 deaths, that number goes even higher, and infection goes up on the list as far as a leading cause. But check out hypertensive disorders of pregnancy. It's a leader, but it's not the leader nationally as far as causing death within that first year. Next slide. But what we do know is that 84%, think that, 84% of pregnancy-related deaths were determined to be preventable. That number should make you go, woof, because think about it. If there was some type of intervention, depending on the cause of death, 84% of the time, you could prevent that death. What a chance for opportunity. And that's where we all come in. Next slide. This is another important piece, which I think will be interesting to you. Nearly 50% of those deaths occur in the postpartum period. So not in the hospital, not during pregnancy, but 7 days to 1 year, 365 days. That's when the majority of deaths occur. And hypertension often falls within this postpartum period. Mandy said to you, if only I'd known. That's where your preventability comes into play. Now, I understand the audience today is in hospital, in most cases, acute care. But you do have a role to play. And this really was where the group of us that came together to look at the hypertensive bundle, even though we've seen a vast improvement in care in hospital for hypertensive patients, we're obviously missing something because it's still a leader. And you saw for Florida, it kind of went right up the charts, despite the fact that you did already once have a concerted effort to address hypertensive disorders. Next slide. So again, you've seen this, but you can see Florida in comparison to the rest of the US and what some of your leaders are, according to CDC, during those two time periods. Next slide. So we came together. Hypertension was one of the original 5 bundles. And the reason when we started this project back in the day, we looked at what are those conditions that we need to really hone in on. We can't do everything. Nobody can, but what are those conditions that will make the biggest impact, the biggest bang for your buck, if you will? Hypertension was one of them, along with hemorrhage and a few others. One thing, though, we knew was, now that we've got some data under our belt, is, a lot of these deaths are occurring later outside of the hospital. And for those of you familiar with the hypertensive bundle, it's very acute care centric, talking about timing of medication, having medication available, etc. Next slide. So we took those bundles and added a piece that was a little bit more community focused. In other words, we recognize that the care can't end in the hospital, and that we need to move outside the hospital and include those resources, appropriate resources, that would help to address this population. So the first recommendation we made was under readiness. There were small tweaks otherwise, and you can certainly take a look at this and you'll see it may differ slightly, especially if you were involved in your first initiative. There's a few tweaks, but this was the biggest change, was to develop and maintain a set of referral resources and communication pathways among OB providers, community-based organizations, state and public health agencies to enhance services and supports for pregnant and postpartum families. Now, I know, and you know, as a labor and delivery nurse, I had no clue what was on the outside of my doors. I didn't. Zero. Didn't. That wasn't my community, if you will. It wasn't within my scope. But guess what? We do need to know. And we need to inform not only our patients, but also the providers. They need to be aware to help assist in getting patients the follow-up that they may need. Who in your community sees pregnant or postpartum patients? Do they know how to treat postpartum patients? I'll tell you, on our MMRC, which I've been involved with for over 20 years, all we kept seeing was people dying of hypertensive crises. They went to the hospital, they had a really bad headache, their pressure was in the 180s over 110s. People looked at them and said, she's young, I'm not too impressed by that blood pressure. Treated the hypertension, gave her something for the headache, sent them home. 48 hours later, they were found having died of a stroke or other. So all they needed to do was ask, have you been pregnant within the last year? That 180 over 110, which may not be impressive in a 35-year-old normally, hypertensive, yes, don't get me wrong, but not the 210 over 120, that may have been recognized like, oh my goodness, she does need to be treated. And she's treated differently than someone that was not pregnant. Are there blood pressure cuffs? If somebody's diagnosed either prior to or before, I love Mandy's idea of gifting a blood pressure cuff, because guess what? You can use that for a lifetime for all your family members. But do you know how to is there access for blood pressure cuffs? Is there some type of reimbursement available? What can you do? And I know as part of this initiative, that will be available to you. Who should I call? What community-based agencies? What are you talking about? Frankly, what is a community-based agency? New Jersey, we're lucky. We have There are 3 agencies, mine and one on either end of the state, and we do very similar things. All of our programs are within this one population. People know if they have any, and by people, I mean community, I mean healthcare providers, know they can call us, and if we can't get access to whatever it is they need, whether it be diapers, a breast pump, or a blood pressure cuff, we can follow up for them. Next slide. So that was readiness. Are we ready to care for this patient, whether in hospital or as they transfer out? Recognition and prevention. The original bundles did not address at all disparities, diversity, equity, inclusion, none of the above. We added a bundle to those original 5 to 6, and it was specific to racial disparities. With that happening, we recognize, why is this a separate bundle? This needs to be incorporated into all the work we do. There is nothing separate about this. So we included in each bundle, and this is where we talk about structural and social drivers, anything that can impact your clinical recommendations and treatment plans. You also want to think about languages. We have a growing Haitian Creole population in one of our more vulnerable cities. That was not there 20 years ago when I practiced in that same community. Do we have materials? What good is it giving materials if you even do that, if you have materials available, if they can't read, if they can't understand? Are there cultural issues that you need to address? Can you speak to both mom and family members as a group? Do you need to do it separately? Are you including in your education more than just the mother? When I had my kids, the last thing I wanted to do is to talk about some of these issues. I was too worried about, am I going to be able to keep this baby alive when I walk out the door, even though I'm a labor and delivery nurse? So it's all of those things. Teaching about signs and symptoms of hypertension preeclampsia and empowering them to seek care. A lot of the work that I do is in the maternal mortality piece. And one thing that I have found, and that's been verified by others, is that we don't always listen to what's being said to us. We may be charting, we may be turning our back to get other stuff, and stopping what you're doing, looking someone in the eye so that you can hear what they say, not unlike what Mandy shared earlier, the CDC materials on the Hear Her campaign, but an active listening. Hear what they're saying to you. And it's not just, yeah, and they're not. So there's something to be said for the old, tell me what I just said, explain to me, and just having that conversation. Next slide. One other thing on the last slide, and you don't need to turn back, is if you're not as comfortable with dealing with patients with hypertension, you really do need to know the physiology behind it. You need to understand the treatment that goes along for it. If what I said earlier about treating a hypertensive woman who is 4 weeks postpartum versus the same age person who has not been pregnant, if that didn't resonate with you or you don't understand why that is, then I do think you do need more education. honestly, until my involvement and my years of experience, it wasn't until then that I really understood that. It never occurred to me that people in the ER should be asking people whether or not they've been pregnant within a year. We're always on this learning journey, so never feel hesitant to ask. So under reporting and learning, we talked about monitoring outcomes and process data for your related to severe hypertension. When you're looking at your patient population, you may have pockets of more at-risk persons. Remember the slide about the difference in mortality between Black women and white women? You will find that if you disaggregate your data according to race and ethnicity, there will be differences, and certain populations will pop as being more at risk. In this particular case, Black pregnant people, postpartum people are more at risk for hypertension than white, Hispanic, etc. You want to include, we've talked a little bit about including not only the pregnant person, but also their family in conversation, as well as making sure that you incorporate pregnant and postpartum people in all of your planning. I did not necessarily realize the importance of this, because I will say, I happen to have been a preeclamptic patient, long family history. I know what it is. But you know what? I don't know everything about my community. I do not realize what resources are there and not there. And that is why the patient's voice is so incredibly important. And I will tell you, I am incredibly impressed by your plans to include family members in your project, because you will learn things that you never knew about your community, who the people are, who are those gatekeepers. I'll tell you, one of our faith-based organizations in one of our cities, if we don't go through them with any projects we initiate, we might as well say never mind, because they have such sway, if you will, with their community in what is done and what is really taken up. Some of this seems like common sense, but it's more than that. You really have to learn what's on the outside, because otherwise your patients will come back. And hopefully they will come back and be able to be cared for and not in any other way. Next slide. So what are the things that I would suggest, and what are the things that myself and others, and the group that made these recommendations, it was a multidisciplinary group. There were physicians, MFM, as well as nursing involved, is ongoing education to all patients on signs and symptoms of hypertension, preeclampsia, regardless of what their history is. I don't care if somebody tells me their normal blood pressure is 90/50, doesn't matter. Because guess what? When they come in at 120/80, I need to be concerned. So you want all patients to understand why it's important that they have their blood pressure checked, they continue, and more importantly, once they go home, that postpartum visit, whether it's at 2 weeks, 4 weeks, or 8 weeks, 6 or 8 weeks, I won't say have to, but they need to go back to that, because this is the condition that doesn't, the old adage, let's deliver that patient and we don't have to worry. We know that's not true. We know that now. Listening And investigating patient-reported and observed signs. It goes back to stop what you're doing, stop the charting, stop the shuffling of papers, stop whatever. Look at the patient. It seems simple, but I've read too many charts to know that that isn't, and patient testimonies to know that isn't, and I know how busy you are. Respectful, equitable, and supportive care. Being open, transparent, communicating with the pregnant and postpartum family, identifying with and identify who their support network is, making sure they also understand. Because oftentimes what will happen is they may share something with a family member who may not be as enlightened as to what the current practice and issues are, and they in turn will negate or poo-poo whatever that patient is complaining about to dire consequences. Next slide. Find out where the referrals are, the communication pathways. We cannot rely on social service or someone else. I don't know about you, but social service never worked nights or weekends and holidays. So you need to know, have something available on the unit to be able to at least provide them right away. Blood pressure equipment is essential, and screening for other types of support is equally important. Next slide. Making sure when you do give direction that you do have that return demonstration, writing down, having folks take a picture with their phone. They may not, I know the old packet that we kept adding more and more papers to and put it in the bag with the extra diapers going home. But you know, and I know, often that packet isn't opened until 6 weeks later, if at all. But maybe a screen grab will be more likely in this generation to be looked at and referred to. Next slide. And of course, including your patient. Take time to assess your patient's knowledge. Educate on those key concepts. We don't have a lot of time with our patients, and there are some key concepts. And the big one, just because you delivered doesn't mean your hypertension's necessarily going away. How to assess, what to do with the information. Okay, now my blood pressure's up, or I have that headache, or I'm extra bloated or edematous. What do I do with that? Who do I call? And remind every patient, you deserve to be heard. And if you feel like you weren't heard, say something. There are many people that are very intimidated by us, and we think we're not intimidating. Our healthcare providers, we need them to know they are in charge. They know their body. And if they have an issue, they need to be heard. And if they're not getting it there, they need to go to the next person. Next slide. It takes a village. You can't do everything, nor can the healthcare provider. You need other supports. Next slide. So what are some tools you can use? Next slide. There's a lot out there. AIM actually has a nice little video review as to what some of the things I just talked about you can access. Next slide. There are other sources of information specific to hypertension and urgent warning signs. So please, I'm sure many of you probably do use A1's post-birth warning signs. I can't say enough about. They are becoming more available in other languages, and more will be coming out on the new year, which I'm thrilled with. It's not every language we want, but there are more than just English and Spanish. Next slide. Find out who's in your community. This may be a great assignment for somebody that's going up the clinical ladder. Find out where you can refer people to, the phone numbers, etc. go look to your professional associations. They also can be of help, as well as your public health and your state Department of Health, etc. Next slide. There are local and national partners that can give you additional information. Next slide. I can't speak enough, not because I'm part of their organization, but the Preeclampsia Foundation has some really on-point targeted materials that are good both for antepartum as well as postpartum. Next slide. There are magnets, just like your A1 post-birth warning signs are available as a magnet. At least it's right there on the fridge. Next slide. Mama's Voices, Mandy already spoke about. This is a group that is phenomenal in training patient advocates to be able to share their story. And there's no more that I can say. Mandy said it all. This is a fabulous group and one that you could certainly refer people to, patients to, once they're ready. Next slide. Preeclampsia Foundation also has a Take 10 campaign. They are compiling a pretty comprehensive database from across the country of patients who have had preeclampsia, and they're using that data to help inform researchers, especially those that are awarded grants through the foundation, to look at the condition of preeclampsia and eclampsia and to see and find. There are now, in fact, they just found there may be some biomarkers that we can look to and a blood test available to actually identify those people at risk. Next slide. So final thoughts, look outside the window, know your community, look for organizations that can assist your families. Think about some of the other needs your families might have, all of which can relate to their anxiety, their comfort levels, etc. And we know that also will affect our patients, especially those experiencing preeclampsia. Next slide. Again, some other types of social determinants, issues that may in fact contribute to a higher anxious or even affect mental health, which in turn can affect one's clinical health, such as preeclampsia. We need to do better. We can do better. I know we can do better because we have seen a difference. Now, are we as good as some other states? Absolutely not. But are we better than we were 5 years ago? I'm happy to say we are, but we've put a lot of effort into the community and involving the community in the work that we do. Next slide. Next slide, that's available to you. Thank you so much. It was a pleasure talking with all of you.